Good evening, everyone. Sorry for the delay. We have had some technical issues at our end, and we are extremely sorry for this. And without wasting much more time, I would like to welcome all the speakers, the panelists, as well as the participants for today's session. I'll quickly introduce the moderator for today. We have Dr. Indraneel Haldar from West Bengal. He is MBBS MD in Pulmonary Medicine, DCH, FCCP, and his special interests are in pediatric pulmonology. We have two panelists with us today, Dr. Deepak Talwar from Delhi. He is a senior consultant and chairman at Metro Respiratory Center, Pulmonology and Sleep Medicine. And we have Dr. Meghnad with us. He's a senior ENT specialist from Hyderabad and the director and HOD of Ma Research Foundation. Today's speaker is Professor Jean Bosque. He's an honorary professor of pulmonary medicine at the Montpellier University, France. He has chaired the GINA guidelines, which is the Global Initiative for Asthma from 1999 to 2000. He is the author of the ARIA guidelines and the WHO Global Alliance Against Chronic Respiratory Diseases from 2006 to 2013. He has a research interest in the mechanism of allergy and multimorbidity and allergic diseases, severe asthma, and the digital transformation of health and care to sustain patient health. He has published over 1,000 papers and is a most influential author in asthma. With this, I would like to hand over to Professor Bosque for his talk. Welcome, Professor.
Thank you, Mr. Chairman. I'm very sorry, but technique and technology is what you want, and it's not always what you can. So we had a problem, and I hope that now you can see my presentation. Can you see it?
Yes, sir, we can see us.
Okay. So first of all, my conflict of interest, they are usual. We're working for many companies, and I have some shares from Masca SAS and Kemedinov. Today, I would like to discuss allergic rhinitis. And we wrote a paper a year ago in the very prestigious journal, Nature Review Disease Primer. This year, the impact factor is 65. So it's one of the top journals. And we said the delivery of cost-effective modern healthcare is challenging for the management of allergic rhinitis and asthma. As management, which is often dependent on specialists and supporting services, is becoming unaffordable and with delays. In France, when you wanted an asthma specialist, it may take 3-4 months. So we need to make things simpler and also to organize this with digital medicine. Authorities should be supported for the transformation of health and care towards integrated care with organizational health literacy. And our app, which I'm going to show you, has been accredited by the European Union and is in process to be accredited by OECD, the development and organization. So we need a global, simple allergy solution. And today, what I want to show you is the following. How can we go from a patient with rhinitis and asthma symptoms to self-care? The pharmacist, I don't know in India if pharmacists playing an important role, but they do in Europe, the general practitioner and the specialist. How can we shorten the time between the patient gets symptoms and get a proper assessment? And this was what we called integrated care pathways for airway diseases to transform health and care systems in rhinitis and asthma. What we need is that the patient-centered approach. Unfortunately, today, we have too many people and too many doctors who are making, CT scan, MRI, and so on and so on and so forth, whereas the clinical observation is essential. This is what our Greek masters told us, but this is what we need to do. The allergic rhinitis management guidelines had an aim to achieve the control of allergic rhinitis, and you will see that this may not be so easy, and to provide recommendation for healthcare professionals. Well, I'm sorry. It is to provide recommendation for a joint assessment shared decision-making between healthcare professionals and patients. Because if you forget the patient, what you're going to propose will not be appropriate for the patient. The issues in guidelines is that recommendations are based on randomized controlled trials. And this is not exactly what people do, because randomized controlled trials are for the registration of medication. This is why we've proposed next generation guidelines based on the randomized controlled trial evidence, but also real world evidence to make the patient at the center of the system. I want to discuss with you today allergic rhinitis management in the peri-pandemic area. 1, guidelines in real life. 2, ARIA, allergic rhinitis and its impact on asthma 2016, and US parameters 2017 and 2020. 3, patient treatment behavior, because this is absolutely vital. How is the patient going to accept the treatment you are going to propose? Then the speed of onset of action of the treatment, next generation guideline, and I will finish by the impact of COVID-19. 1, guidelines in real life. Well, as I told you, randomized controlled trials are considered the gold standard evidence for assessing efficacy of a treatment intervention, but they are designed to answer regulatory questions. And this is absolutely necessary for drug registration. It is the best way of assessing effect size and determining cause and effect relationship. But the answer is tightly defined on the question. And the question is not clinical evidence. It is this medication or treatment effective? Well, we did a study several years ago, and we assessed how many patients could be enrolled when seen by a general practitioner for a randomized controlled trial in allergic rhinitis. And you see 7.4%. This is the same for asthma. So most of the patients seen in general practice and even in your clinic do not fit with the guideline because they are not exactly the same patients as you are going to see. The second issue is that in randomized controlled trials, and this is a GSK study because it's an excellent study, and what they did, they assessed fluticasone fumarate, 2 strengths, and placebo. But the adherence to the treatment should be 70%. You will see later what it is in real life. So in a clinical trial, if you don't have an adherence of 70%, you don't have something which is valid. On the other hand, guidelines work. And this is a study we performed over 20 years ago. Well, we are very brave to do this study, and it was very difficult to get it accepted. Why? Because we used quality of life as the primary endpoint. Well, we treat patients to improve quality of life. And secondly, we compared a free treatment choice made by the GP and a consensus treatment. And we found that both treatments were effective, but the consensus treatment was better than the treatment choice. So even though guidelines are not fully adherent to patients, they are still effective. However, we need to combine real-world evidence, which is randomized controlled trials, real-world data to complement randomized controlled trials using a patient-centered approach, and chamber studies to assess the speed of onset of treatment. And this is what I'm going to show you now. So what are the ARIA 2016 and US parameters 2017 and 20? Well, by the way, both used the grade evaluation. So for the first time, the US and ARIA guidelines had similar value. And in fact, this is the ARIA guideline, and this is Rhinitis 2020. There's a problem here. They proposed 37 recommendations. However, only 3 were based on grade. And I think this is very important indeed to say that in most recommendations of this study, the grade approach could not be made. On the other hand, in ARIA, all our recommendations are based on grade. So there is still an improvement which can be done using these guidelines. Now, I would like to go to patient treatment behavior. This is new because we give a prescription to the patient and the patient takes or doesn't take the medication or the treatment. So in real life, what can we do? So we use an app, which is not in India, but it is in 30 countries now. And this is very simple. Number one, 4 questions. Overall, how much are your allergic symptoms bothering you today? How much are your nose symptoms bothering you today? How much are your eye symptoms bothering you today? How much are your asthma symptoms bothering you today? 28 languages, 28 countries, and we have now 55,000 users. This slide is a bit old, and we have all medications for the given country. So it is something which is extremely extensive, and we have plenty of data to assess. It is totally free on Android and iOS, but it should be in the country due to regulatory issues. So it's not in India. Well, an example here, 41,000 days, we're the same with 500,000 days, but when you have 500,000 days, it's totally obscure. And here you can see that when you're asking, how are you today for your allergy symptoms? Or how are your nose symptoms bothering you today? You have an excellent correlation. So we validated almost everything there, and we know that when we give result, the result is validated. First question, adherence to treatment in allergic rhinitis using mobile technology. Here, we studied 7,000 subjects. Among the 7,000 subjects, there were 860 reporting from 7 to 30 days. And among those, that to say among 12%, only 5 to 12%, depending on duration of reporting, only 5 to 12% were in fact adherent. So overall, adherence is extremely low. Remember, for randomized controlled trials, you need 70% adherence. So it's totally different. Secondly, and I think that in India, this is the case, and in India, you also have non-medical medicine, non-medical treatments, and these are probably very good, but they're not sufficiently well tested. Self-medication, 50%. So there are guidelines based on randomized controlled trials that do not reflect what patients are doing. Second point, guidelines tell you need to increase your treatment in order to be better. Here, we showed in something like 10,000 subjects, 350,000 days, so sufficient number. And this is the same in all countries, that when you don't take a treatment, you are better. This is surprising because you would think that people without treatment would be better, would be worse, sorry. But no, if you are not well, then you take 1, 2, 3, 4, or over 4 medications. And the more you take medications, the worse the control. So it's very surprising indeed to think that when you increase your medications, you are worse. This study is extremely interesting, and it's probably one of the best studies we have done. We have studied the medication patterns in 10 countries, but I'm going to show you 3: Italy, France, and Germany. As you can see, there is a peak every year during the pollen season, except for 2020 because there were COVID issues in Italy. On the other hand, the same medications are used in Italy, France, and Germany. They are oral antihistamines and oral antihistamines plus intranasal corticosteroids. You know that this is not in the guideline. So patients treat themselves during the pollen season when they have symptoms outside of guidelines. Second point, we studied the cultural differences between the 3 countries. In Italy, people think to allergy when they use Google Trends. In France, they think to allergy and pollen. And in Germany, they think to allergic rhinitis and pollen. So, despite the cultural differences between countries, the same treatment is used. Now, what is the treatment sold in pharmacies in 2018. So, 2018 is the peak here. There are big differences between countries. So, patients do not think rhinitis the same way. Patients buy different medications, but they treat themselves the same way. This is a behavioral pattern. And I think that this study tells us that our patients are adherent to their symptoms. That's all. Well, we then assessed the treatment effect. And this is the first study with a small number of patients. It's exactly the same with, I would say 400,000 days and 20,000 patients. Here, in green, monotherapy. In dotted blue, untreated days. As I told you, untreated days are the best. And they're similar in azelastine fluticasone, fluticasone furoate, and mometasone furoate. They're worse for antihistamines like cetirizine and desloratadine. We don't have montelukast or the combination because it's not well used in our countries. So first of all, when you take a single treatment and you are well, you don't change. When you change co-medication, they are always worse. This is again guidelines. But the most interesting thing is this. When you take azelastine fluticasone, in 60 to 70% of cases, the patient only takes monotherapy. With fluticasone furoate and mometasone furoate, the patient takes monotherapy only in 30 to 40% of cases. And this is what is important. The patients want to be well. When the patient is not well, the patient increases the treatment and does not necessarily reach control. So it is against guidelines. When patients are well, they do not take a medication. They increase the medication to be controlled. But some, possibly many, patients cannot be controlled. And these observations do not accord with guidelines that propose to increase treatment to achieve control. So you see, real-world data are totally different than the data that are proposed. But then we use in here 8,000 users. And here we have up to 290,000 days. Very simple. When patients are well, in dotted lines, they are well controlled. When patients are under azelastine fluticasone in blue, intranasal corticosteroids in dotted orange, or Dimista plus another drug, they're pretty well. Oral antihistamine is in between. Worse is oral antihistamine plus intranasal corticosteroid, with a minimal important difference perfectly met. And finally, the worst of all is oral corticosteroids. So these data do not accord with what we're thinking. And this is the next point is that our patients want to be treated fast because usually they don't have medication when they are well, and when they are unwell, they want immediate relief. And we did a study in the chamber. And in this chamber study, we compared azelastine fluticasone in dark blue, fluticasone propionate intranasal plus loratadine in orange, and placebo in gray. As you can see, azelastine fluticasone is effective in 5 minutes. Fluticasone propionate plus loratadine is effective in 150 minutes. So there is a big difference here. And this difference has to be considered. And if you look to the different treatments, you will see that combination between intranasal corticosteroids and intranasal antihistamine is probably the best. So we need to go to next generation guidelines. I'm going to show this guideline. This guideline was published in 2016. It is the ARIA revision. And it has been considered by Gordon Goyat, who is the Pope of guidelines, that the clinical scenario of his JMA paper was on ARIA. It is the paper Brozek-Bousquet-Nagash, and you see Brozek-Bousquet-Nagash. So we know that ARIA guidelines can be used as a model of guidelines. However, we think that the ARIA guidelines are not sufficient because we said at initiation of treatment, first 2 weeks, the combination of intranasal corticosteroids and intranasal antihistamine might act faster than intranasal corticosteroids alone, and thus might be preferred by some patients. Patients do not wait 2 weeks, they want now. And I showed you before, in the slides before, that some treatment can be effective within minutes. And this is what our patients want. So what we have done now, it is next generation guidelines where we are assessing the GRADE guideline and we are including the patient real-world data and onset of action. I'm going to show you why. Because the next generation guideline is the first GRADE guideline integrating real-world data and chamber studies. It provides a clear strategy to identify the approach to treatment. Step up, step down, continue or start. The treatment approach is based on visual scale. You know, when you have a patient, you're asking the patient, how are you today? If the patient tells you, well, doctor, it's terrible, then you treat the patient. The patient says, oh, you know, doesn't matter. Then you don't treat the patient. It is the patient who tells you what to do in rhinitis. In asthma, it's not the same, but in rhinitis, this is the case. It is the first guideline to provide a specific treatment recommendation based on current treatment, visual scale, presence of congestion, exposure to allergen, and this was done by a consensus meeting. I'm going to give you some examples. Oral antihistamines. Well, GRADE and real data show that they are less potent than intranasal corticosteroids, but many patients prefer oral drugs, and many patients are well controlled. And when they are not well, patient takes oral antihistamines. So this is something to be considered. We go from GRADE to real-world evidence and to the patient needs. Even now we take intranasal antihistamines. They are less effective than intranasal corticosteroids, but they are effective within minutes. And some patients use the two medications. But when you have the single medication, it's even better. Intranasal corticosteroids, they are potent medications, first-line therapy in moderate severe rhinitis. Yes, GRADE and real data, but the onset of action is delayed. And patients want to be treated quickly. If you have rhinitis in, people who have rhinitis in this, not room in this symposium will know that they want to be treated immediately. They don't want to suffer, like me. Then, if you take intranasal corticosteroids and oral antihistamines, GRADE and the US parameters and ARIA say, well, there is no major efficacy. That's not exactly true, because some patients tell you that adding an oral antihistamine to an intranasal steroid may help if the treatment is given not continuously, but at some points. Finally, intranasal steroids and intranasal antihistamine. Well, faster and better treatment. So this is really one thing which is to be considered. But patients may be treated with oral antihistamine, with montelukast, with intranasal steroids. So you need to consider the patient, what he tells you or she tells you, and what you want to give. We didn't assess montelukast and antileukotrienes. Why? Because this treatment is not widely used in Europe, and I will tell you why. In Europe, the reimbursement of montelukast is only given when you have asthma. So this is not what we want to do. So there is a meta-analysis which is excellent and which was published recently. So they studied 15 studies which met criteria of good trials. These studies show, number one, if you compare montelukast and oral antihistamine versus oral antihistamine only, it is better. And I think that in India, we have this, well, it's very nice that you have this combination that we do not have in Europe. So we cannot test it, but this meta-analysis is clear. And in fact, this meta-analysis said Montelukast is effective in treating the overall symptoms of allergic rhinitis when compared against placebo. It is effective in treating the nighttime symptoms of allergic rhinitis. And this is important because people can sleep. And combination therapy of montelukast with an oral antihistamine is superior to either an oral antihistamine or montelukast monotherapy. So in India, you are lucky because you have this kind of combination. And many patients, I was told, are perfectly well controlled with that. That's wonderful because people prefer oral drugs, and this is a more potent drug. So you have many possibilities from oral antihistamines, which are sufficient in the large number of patients, montelukast and oral antihistamine, which are also sufficient, intranasal steroids. Intranasal steroid plus oral antihistamine, I would not say that this is an option, and intranasal steroid and intranasal antihistamine. So we have a wide array of different medications, depending on the patient's will, oral or intranasal. And possibly you may start by intranasal and then continue by oral. And in India, you have montelukast and oral antihistamine, which to me represent a very serious option. So what do we have? First of all, we need to decide on the treatment approach. Continue the treatment, step up, step down, or initiate. And then we need to assess which treatment. And as I showed you, we have different possibilities. So you may also propose a first treatment with montelukast plus oral antihistamine, and if it doesn't work, then you either add or you replace by an intranasal treatment. So what I told you here is that what we have done is an area digitally enabled, integrated, person-centered care for rhinitis and asthma. And it has been recognized by the EU as a good practice of the EU. And it has been proposed by the EU to OECD, the Organization of Economic Development. So we hope that within a few months, what I'm showing you will be endorsed by OECD, and then we could go to governments. We shape the single market in order to change management with a patient-centered approach. This is our goal. And this is what we would like to do with the help of the patients and the help of you, because we need you in order to provide the best treatment for our patients. Now, I would like to go to COVID-19. Well, there are many possibilities. I am not going to discuss telemedicine in COVID-19, but I'm going to discuss digitally enabled patient-centered care in rhinitis and asthma. So we assessed which are the COVID-19 questions. And with Jan Hagemann, with Ludwig Klimet and many others from ARIA, we proposed what are the symptoms of COVID-19. And what we proposed, and this is, where we are. So it was a worldwide assessment. And we had many different symptoms. So we recorded the symptoms. I'm not going to discuss them now because there is a second study that we have done. The second study is the olfactory dysfunction in wild type and Delta variant. And olfactory dysfunction is more important in wild type than in Delta variant. So there are differences, but there are also differences in your country, because in your country you are eating a lot of spices, and probably the receptors for taste differ from Europe, where we don't eat a lot of spices. So there are differences between countries and differences between variants. We also did a paper which has been published 2 weeks ago in Allergy. It was the difference between the different variants. And here we had the wild type in black, Delta in blue, and Omicron in red. And you can see that there are big differences between variants. For example, respiratory symptoms are more important in wild type and in Delta than in Omicron. On the other hand, there is in Omicron little taste and dysfunction. And on the other hand, there are more rhinitis. So the different variants do not appear to be the same. And this is what we need to do. So if we compare common cold and sore throat, bronchial and pulmonary symptoms, systemic illness, and olfactory impairment, it differs between the type. And the new types will probably be different. Now, what is the impact of COVID-19 on digital health? Well, we studied this with Bernardo Souza Pinto, and we assessed the impact of media coverage on one symptom. It was the nose, the smell. And as you can see here, these are Google Trends for anosmia, ageusia, and you see that there is an enormous peak at the beginning of the COVID pandemic. So the Google Trends were not due to real ageusia or anosmia, but were related to COVID. And it's very important when we're discussing COVID with patients to disentangle what is due to allergy and what is due to COVID. Finally, we assessed anomalous asthma and chronic and COPD trends. And you see again that in red, there is acute pneumonia, in blue, asthma, and acute pneumonia and asthma were much higher at the beginning of the pandemic. And you see that there is no trend for diabetes and little trend for COPD. So when you see a patient during the COVID pandemic, you need to understand what kind of COVID it is and how this COVID may impact. And there might be differences between countries we do not know. Finally, when you have common cold, as you see here, in Japan, for example, the reporting of common cold was very, very low during the COVID pandemic. So COVID is changing considerably the way we are seeing patients. So ladies and gentlemen, I've tried to show you in about 35 minutes or something like this, that guidelines are going to change. They're going to change because we need a patient-centered approach. But also they're going to change because there are new factors that we didn't know, like COVID. And I hope that within the next 18 to 24 months, we'll be able to come with new area guidelines, which will integrate all these issues. Thank you.
Just before Dr. Indranil takes over, I would just like to remind all the participants that everyone, if anyone has any queries, they can put it in the question and answer section. Over to you, Dr. Halder.
Okay, thank you, Ketan, and thank you, Professor Bosque. And we have Dr. Talwar and Dr. Meghnad here, and we are fortunate that we are having one pulmonologist and one ENT specialist also among us. So, after an excellent deliberation by Professor Bosque, we have already had an idea of what allergic rhinitis, how it is being treated, about the new ARIA guidelines. And so let us start with the first question, that with this COVID, did COVID lead to change in the incidence of the allergic rhinitis globally? So after the COVID, are we seeing more of allergic rhinitis or less of allergic rhinitis? What do you, Professor Bosque?
I don't know. This is a simple question. I think that we will know in 3 to 5 years when we will assess the prevalence of allergic rhinitis worldwide, and that we'll see whether the prevalence has changed or not. What I can tell you, it is that allergic rhinitis is much less impacted than asthma in terms of symptoms.
Okay, Dr. Talwar, do you...
But this is a very good question.
Dr. Talwar, are you seeing more of allergic rhinitis or less of that just after the COVID era? Then I'll come to Dr. Meghnad also.
So, Indranil, I think you will also echo with me on this aspect that I do not know, because India is a big country. So obviously, you know, there is a lot of geographical changes which happen at different times of the year. But the last 1 year after we started seeing the patients, we realized that there are a lot of patients who are having post-COVID symptoms which persist for a longer period of time, which are actually the allergic symptoms, which never troubled them too much in the past, that they never approached the doctors for the treatment. And I think they were on home remedies, which was good enough for them. And now after the COVID, whatever the viral infection had upset the entire system, that the symptoms are more pronounced and they're more persistent and they need more treatment. So whether the numbers have increased or it is the severity which has increased, that's a question which is totally different. But I feel the severity and their presentations have increased. They had symptoms, but they were mostly in the form of mild intermittent, where they did not need much of a treatment. But now they are more frequently reporting to us with the symptomatology.
Dr. Meghnad, are you, as an ENT consultant, are you seeing more of those cases, more severe cases right now after the COVID?
Yeah, during the pandemic, when there was a lockdown, I think we have seen very, very less number of allergic rhinitis, because we know very well that diesel exhaust product, DEP, in the atmosphere is very low, and many allergy patients were telling that we are very happy, we are not requiring any medication. But at the same time, post-COVID, a new set of allergic rhinitis patients have cropped up, as Dr. Deepak mentioned. But at the same time, some of the old allergic rhinitis patients, they're much better without any medication. So there is some alteration in the allergic rhinitis patients' demographic. Dr. Deepak, have you seen very low number of allergy patients during the lockdown period?
Yeah, that I completely agree with you that during those 3 to 4 months of lockdown, there was hardly any complaint and hardly any patients contacting us for that, because asthma patients were also contacting us, but they were more out of scare, but they didn't have those asthma attacks. Their even allergic rhinitis was under control. They didn't have a problem. But after that, so this was somewhere around, I think, the October onwards of 2020, we started noticing that they have started coming in. And after the Delta wave, that is the April 21, there is a surge. This surge is of all new cases. Very rightly, you said those who had disease, they knew how to treat it. Actually, they had learned it. But these new batch of people who were like, previously never taken any treatment, they are the ones who really reported for the treatment, and they wanted a treatment because their symptoms were definitely much more severe, and they were lasting. Because initially all these patients did get treatment with montelukast and fexofenadine and some kind of beclomethasone or a budesonide inhalers, and they were doing well. But most of the times, it was considered that these are post-COVID symptoms. They were switched off at, 6 weeks to 8 weeks. And then these symptoms reappeared. And this is the time when they came up. And that is the kind of thing we have been seeing.
Sir, is it that old asthma, very long-standing asthma patients have got some protection against the COVID?
So, Deepak, I lost my network. So, am I audible right now?
Welcome back, Indranil. We can hear you now.
So, am I audible, Deepak?
Yes, you are, but there is some echo coming. I think there are two devices.
No,
There are
he
two
joined by
devices.
2 devices.
Yeah.
Okay. Now, please.
Indranil, you have to switch off one device.
Okay. So, Deepak, next question to Dr. Deepak. So we are seeing a lot of waves. In fact, the first, second, third, and now also we are having one of the COVID wave. So do you think that with this COVID, should we have a change in the management of allergic rhinitis right now? Deepak?
So I know, we had a lot of unresolved issues during the first wave, and maybe 6 to 8 months later, because nobody had an idea what is to be done. So primarily, lots of sinus washes, the steam inhalations and things like that, people were taking to prevent getting COVID. And this was done to an extent where it was too excessive. But over the period of time, we have all realized that actually the treatment would remain the same. And if it's an allergic rhinitis during COVID or during not COVID, the treatment is same. And it is depending upon the severity as well as the treatment which the patients are taking, which beautifully has been explained by the next area, which is generation area, which Professor Buse has very nicely explained, that What all matters is actually the phenotype, the symptoms of the patient, as well as the amount of treatment which the patient is taking. And I think if we go through that, perhaps the newer one will be much more akin to what we are doing in a clinical practice. I'm very happy to see Professor Guse bringing in the point where the combination therapies do work better. Only thing is the cost factor, but we know that in India there is not a big deal about the cost. The dual nasal sprays as well as the dual therapies of oral montelukast and fexofenadine or levocetrazine, they almost cost not much different. So patients are for a quicker response. So there's no doubt that now the data is to suggest that these two drugs together, when they're used in the intranasal preparations, they do better. But that is the best way forward for all the treatments during the COVID, after the COVID, before the COVID. And as far as India is concerned, I think patients have also learned to use them as a dual therapy for 2 to 4 weeks, which they do whenever there are symptom worsening happening. Because all of the patients who do not have a persistent symptoms do tend to fall out of the therapy very soon, because they feel all right. So I think that rule which Professor Guse has said is very correct. And I think it is all across the world, that if you feel all right, you will not take the medicine, because you don't feel to take the medicine, need to take the medicine. So if they really don't need to take the medicine, we cannot keep on pushing them to do it. And even if we do it, it will not last for the lifetime. So it's basically driven by these symptoms. And that symptoms-driven treatment has to be given to these people. And those who persist to have symptoms much longer, they will be obviously the patients who will require a different approach altogether.
I cannot agree more.
Yes, Professor.
I think that you make a very good summary of what the patients are doing across the world.
Indranil, are you still getting into trouble? So, Doctor,
Yes, Dr.
Carry.
So can we, Dr. Buske, during the COVID era, do you think, how do we set up a COVID allergy clinic? We want to get from you, sir, how to set up an allergy clinic during the COVID era.
Well, most patients didn't come and visit. I tell you, asthma patients who are coming and were phoning, rhinitis patients didn't. At least in my practice.
I fully agree with you. Actually, these are the patients who didn't come during those times at all.
Voilà.
Dr. Megnath, how was your clinic for the allergy running during the COVID times, like allergy tests and other things? How were you doing it during the last year, like 2021?
We have been doing the allergy skin prick test in our hospital. And what we have done is we have 0.3 micron filters in our air conditioned systems and also in the rooms, in all the chambers. So practically, we didn't look into the COVID as an issue. We have treated around 4,000 patients in the OPD, around 300 patients in the inpatient wards during the COVID first and second waves. And honestly, not even one staff member got COVID. And in fact, those who have gone on leave, 50% got COVID.
Okay. So, Indranil, are you able to pitch in? Can't hear you. You are on mute, Indranil.
On mute. So, can you hear me right now?
Yes.
Okay. So,
you have to
Dr. Megnath.
Otherwise, we are getting echo only.
Okay. Can you hear me right now?
Yes.
I can hear you, but there is echo. You have to.
Not for me. I don't have an echo myself.
You have logged in with two devices.
Okay. I'm just. Dr. Meghna,
Yes.
what can be done for personalized allergic rhinitis management in India? Because we want is personalized management. So what can be done for that?
Yeah, personalized in the sense that we have to go with the symptoms. There will be different pathways in the allergy, and all the pathways may not be stimulated in every patient. We know very well some patients, they have more of rhinorrhea, some patients have more of nose block. And I strongly recommend montelukast in those patients who are having the nose block. And for initial few weeks, I do add decongestant, the oral decongestant, but not the intranasal decongestant. Because the tachyphylaxis is very, very rapid with the intranasal antihistamines and decongestants. But one important thing is even there are ocular.
We can't hear you.
I think there is a net issue there. Indranil, you can shoot a question.
Okay. So I was asking for personalized allergic rhinitis management. Dr. Talwar, do you have any views on your part? How can we personalize allergic rhinitis management?
I think to me, personalized treatment would be different in allergic rhinitis as compared to asthma, where you have a more targeted therapies to be used for a specific severe asthma patients. Like we run the severe asthma clinic, we use it there. But in allergic rhinitis, the people come with a different ideas. Even if they have a mild intermittent symptoms, which come during the periods of their exposure to the allergens, they are looking for permanent solutions. So immunotherapy is like one of the options which is given to them. So we have to cater in allergic rhinitis only patients according to what is their demands actually. Some of them will be happy to take the medicines as and when required, but some of them would look for a permanent cure. Some of them would definitely look for, after undergoing the FES and other kinds of surgeries for their nasal polyposis, again look for an alternative treatments where they can actually undergo a kind of a therapy which gives them more longer lasting effects. And they do not wish to go for a surgery again. So I think we are dictated in more or less in allergic rhinitis as a personalized treatment from the patient's perspective, rather than the phenotype and the endotypes which we do and deal with in asthma. So it's a little different from that.
Professor Jain, we are in India, we do use a lot of antihistaminics, and we are yet to get an ideal antihistaminics. So according to your view, the upgraded or the ARIA guidelines that we have right now, does they grade an idea of scores?
So I cannot hear you. I'm sorry, I couldn't hear you.
So can you hear?
Yeah, there's some problem in the net connection at your center. So you are not able to be clearly audible because it's breaking.
Okay, let me switch on from another device. I'll be switching in from another device. So we use antihistaminics and we rely on antihistaminics. Am I audible, Dr. Talwar?
So I think, Indranil, your question is that we do not have an ideal antihistamine.
Absolutely. So does the upgraded ARIA guidelines guide us in some way in the ratings or in the score for an ideal antihistamine?
Okay, so I think this question is...
The simple answer is no, because we're considering drug classes and not drug molecules, because there are too few data on drug molecules, and head-to-head comparisons do not exist. So we are discussing classes at the regular dosage. We're not discussing multiple antihistamines in the same patient. We're not discussing different medications because there is no head-to-head comparison. And since there is no head-to-head comparison, we cannot make any recommendation.
Okay, thank you. That should be the answer. So, Dr. Talwar, so when we manage severe allergic rhinitis, who have comorbidities like asthma, nasal polyp. What is your answer to that? How do we manage allergic rhinitis with severe asthma or nasal polyps?
That's the group of patients, Indranil. I would love to use biologicals, and anti-IL-5s are the drugs which we are currently most excited about using it. Unfortunately, we don't have a IL-4 blocker. We have only anti-IL-5 blockers. Two of them which are available are mepolizumab and benralizumab. So we try to use them particularly because those patients of nasal polyposis who have no smell, has undergone FES surgeries, have severe asthma along with it, and there is a blockage which is troubling them, and they're on oral steroids. So these are the people which we have used mepolizumab as well as benralizumab. I will perhaps ask even Professor Buse that what is his experience about using these versus the anti-IL-4s, because we see the guidelines recommend IL-4 as the first one in these situations. But since we do not have that, we are practically dependent on anti-IL-5s.
Well, first of all, there is a meta-analysis which was published recently in the JCI. I'm one of the authors. And apparently, dupilumab is more effective than the rest. Number one. Number two, these are not patients with allergic rhinitis. These are patients with nasal polyps, which is a totally different disease. And they have nasal polyps and asthma. So we're discussing different things.
So
I'm sorry, my connection is very bad. I don't know what it is in your place, but my connection is going up and down.
But we can hear you clearly, Professor.
Okay.
So, sir, please continue from where you have ended. So Dr. Talwar will come back to Dr. James once we get the network. So the next question will be an ENT question, and I'll be asking my ENT colleague to answer it. So we have a lot of allergic rhinitis patients who present with severe nasal congestion. So how do you manage those patients of allergic rhinitis with severe nasal congestions? And do you think that there are some roles of nasal decongestant in the management of allergic rhinitis? Dr. Meghnad?
Dr. Haldar, Dr. Meghnad seems to have dropped out of the call. Maybe some technical issue. Maybe Dr. Talwar can take the same question.
Okay. Dr. Talwar, what do you?
So those who have a severe congestion, they generally require an oral decongestants. And then we don't find the newer ones very effective. In fact, we go back to our older ones and they seem to be doing much better to them. Although they are very sedating to the patients and they're not very happy with them. But more or less, if you persistently use your combinations of oral antihistamines with montelukast, which are currently the choice which we have excellently available to us, it takes some time for the symptoms to go. It doesn't disappear so easily. So I'm practically very not happy on this aspect that people keep on using their oxymetazoline, the nasal drops as frequently as they are using, and despite our all persuasion to tell them and discussion about the side effects and rhinitis medicamentos, they get quick relief from that only. So they continue to use that. And that is something which we see even in today's practice, that there are patients who are very difficult to wean off from oxymetazoline.
Absolutely. So again, in India, we rely more on oral medications, oral combination of montelukast, levocetirizine, or even oral decongestants also, rather than inhaled nasals, that is intranasal steroids. So underuse of intranasal steroids is practically what we see in India. So my next question to Professor Buske, so can you please tell how you differentiate patient profile for those on oral combination therapy versus those on intranasal steroids?
We don't have oral combination. We don't have in France.
So that's very good, sir. In place, you don't have any combination. But in India, the most prescribed drug are the combinations of Montelukast with levocetirizine or Montelukast with
I
fexofenadine.
know, but this is something we don't have in Europe. So I cannot tell you. And the data are not sufficient to be compared. I showed you a meta-analysis. It's all I could find. 500 patients only.
Yes. So Deepak, do you ever prescribe this combinations of antihistaminics with Montelukast in your patients of allergic rhinitis, or who are the group of patients, or whom do you think that this combination may work?
As I told you, Montelukast can only be given in asthma. Otherwise, it's not reimbursed. So we have, unfortunately, we don't have enough information on this. And I think it would be very important to do the proper studies and to compare these studies to check what is, first of all, you need to check the speed of onset and the efficacy. Secondly, you need to assess how much you're getting better than single treatment alone.
So thank you. Dr. Talwar, can you hear me, Dr. Talwar?
Yeah, I can hear you now.
So your experience on oral combinations of Montelukast, levocetirizine, do you really use them or you don't use them at all?
So we use them when it is associated comorbid asthma. There is no doubt about it. There we will be definitely using it. But in isolated allergic rhinitis, also it is used. And it is primarily because when you start with the intranasal steroids, it takes little time to get to the effect. So at that time, you have a choice of either combining it with an intranasal antihistamine or to combine with oral therapy along with it, which is invariably available to us as Montelukast with fexofenadine or levocetirizine. As Professor Busse has already clarified, there's not much data available in it. And obviously, we personally feel that, in the initial 2 weeks, it does make a difference to the patient. After that, you can obviously continue with their intranasal steroids only on a long-term basis. But then eventually they will leave that also because they feel well.
So, Dr. Talwar, we see a lot of patients who are on intranasal steroids and also on an antihistaminic. But once they stop their antihistaminic, even with the adequate dose of steroid, they again go back to their symptoms. And they practically, even in spite of a request, they don't stop these antihistaminics. What is the problem with this patient? How do you tackle those patients?
So this is, I do not know whether we'll call it a step-up therapy for those people who have more symptoms. And as I think is shown very nicely, Professor Busse, that, this step-up doesn't make effect all the time. Actually, it's not supposed to be so good as the data shows. So these are I think this is more in the Indian context because Indranil, our patients have learned that, this kind of a combination is actually a home remedy now, practically. Every house knows about it. Anybody who sneezes, there will be immediately pop-up of one tablet of this, which will be given to that member without any doctor's prescription, without any consultation with the doctor. And to themselves, when they relapse, when they suffer more symptoms, they immediately start with the same treatment again, which is again the same tablets which they are taking and perhaps the steroids or other things. But then I think this is also a common experience that symptoms don't resolve so well, even with all this treatment given to them, actually. So it doesn't work so well. So then that's the reason they'll come back to you and again ask you that what more treatment is required, and you will try to tweak in and see that if anything better can be done, or there is some technique which is wrong, or the way that medicines are being given is not required, or they have infections in the sinuses which are precipitated at this point of time. So I think the treatment I personally feel is that only a group of patients of allergic rhinitis and allergic sinusitis without nasal polyposis are the group of patients who are on a higher scale of symptoms only come to the doctors. Otherwise, they don't respond. They don't come to the doctors. They take treatment on their own. They have learned the treatment, and more so after COVID, because everybody knows in the COVID, they have been told that these are the drugs which have been used. These are repurposed drugs. They work in taking care of symptoms of COVID as well as of long COVID.
So again, another important question, Dr. Talwar. The thing is that practically in most of the cases, allergic rhinitis is diagnosed clinically, at least by the pulmonologist here. ENT specialists definitely go for an examination of the upper airways. They do have their instruments. But when do you think that diagnostic test, which include the allergic skin prick test or some other diagnostic test, may be necessary in your patients of allergic rhinitis? Is those in those patients who are really uncontrolled, or in each and every patients of your allergic rhinitis, you go for investigation?
So those who are uncontrolled, they have moderate to severe disease, we definitely go ahead and do the testings. So obviously it's IgE mediated, or it's non-IgE mediated, or it is eosinophilic mediated, and or whether there is associated with polyps, whether there is an obstruction there, which is requires a surgical correction. All these things are done in uncontrolled patients only. But those patients who do well with the initial therapy, we do this test only when they need some kind of, as I said, that personalized treatment where they're looking for a permanent thing. So they want an allergy test, they want to see what to avoid. Is there a immunotherapy option available or not? Because we know that we don't have those FDA approved sublingual therapies available. Whatever is there it's a local therapy which is available. So we generally use only slit, not the slit if it's available. But the subcutaneous immunotherapy is given to house dust mite as well as to some other pollens. But by and large, this is not a very standardized kind of a therapy which is available. But these are the therapies which some of the patients do need. And this is particularly when, their symptoms are more related to the environment where they cannot avoid the environment. So these are the kind of things in which even if they have intermittent symptoms, but they suffer during those couple of months or couple of weeks of the year, we do test for them by the allergy test and other tests. Even imaging studies and other things are also included in their evaluations, but not routinely for every patient.
I think this is absolutely right. And this is what we do.
So do you do a skin prick test or the IG specific test that you do here, the immunocap test that you do?
We do skin test in our clinic, and then we eventually do immunocap.
So in India, practically the standardized antigen is not available in most of our place. So even if we go for a skin prick test, knowing fully well that it is the gold standard, the standardized antigen, getting that is very difficult. Deepak, what's your comment on that? And how frequently do you do the immunocap test for the allergic rhinitis patients?
Yeah, thank you, Indranil, for asking this question. Actually, prior to COVID, we were heavily into the skin prick tests only. During the COVID, there was a shift towards the specific IgE testing. Specific IgE, you are correct, because these kits are all imported kits. So they have these kits which are coming from abroad. They are quite standardized. They give the answers. But correlation is ultimately on the skin prick test only. So you need to confirm when you go for your immunotherapy with a skin prick test for that. As far as the standardization of the skin prick test reagents is concerned, I have no doubts about it that we do have problems with that. Previously, we got products which were available from Germany, which were available for the testing, but now they have been also withdrawn from the market. So we have really, last 2 years, because this were withdrawn, so we had a practical shift towards the specific IgE testing. But specific IgE testing does pick up a lot of positive tests, which is not clinically correlated with the patient's symptomatology. So you really need to do more hard work there, much more hard work there. So that is why what Professor Buse says that, they correlate both the data of the test together with the clinical symptomatology of the patient and then decide upon the therapy, which becomes expensive affair for us, because doing 2 types of tests itself for a patient who's self-paying will almost increase the cost to quite significantly higher. But that's the way forward. And only thing is, because of the COVID, I personally in our lab, Professor Mangesh had different opinion that they were doing all the tests during the COVID time. That's fine. But for us, we almost 1 year, we did not do the skin prick test, and we were all into the specific IgE. But believe me, with the specific IgE, we could not offer immunotherapy to any patient at all, actually.
Cost factor is also important, Deepak. The cost factor is also important. In fact, for a single antigen, it comes to about 500 INR or something like that. So if you want to do 20 antigen, it comes to about double the cost of the skin prick test.
Very rightly said. Very rightly said. And some of those in the ready-made kits are the antigen, the allergens which are actually not available in. They are not practically possible to be in the atmosphere of India. So basically, these pre-made kind of the kits for the immunological tests are not very suitable to India at all, actually. So we don't get burst, actually. So if you see, you start testing for them in the India, there's no point for that, actually. There's really no point. So if I tell the patient that you are becoming sensitive, he brings a report that he's sensitive to German cockroach. So he asked me that, where do I have German cockroaches for me in my house? So like different things which are there with these pitfalls. But obviously, I think the companies need to improvise with more, the kits which are centered toward the Indian allergen and the pollen calendars rather than the Western completely. So we need to actually do a lot of homework there.
So now my next question will be related to technology. So in the lockdown phase, we have seen many digital tools coming up in our way to ensure continuity of this service. So my question to Dr. Professor Buske, from disease perspective, do you think that there are areas where digital interventions can benefit our clinical practice to our patient? We have already talked about the must study and all those. So do you think that there are some digital tools, not that difficult, but still we should implement in our practice?
Well, this is what I would like, and this is what I hope. So what we need to do is to really do the studies. Up to now, we've shown that our app is relevant and can make new information. What we need to do is to compare patient not using the app and patient using the app, and to see what will be the outcome in 1, 2, and 5 years. I think that digital technology brings something, otherwise I wouldn't do it. But I need to show it.
Thank you. So Deepak, your innovations in digital technology, how you have implemented, because I know you are more tech-savvy in that way.
Well, first of all, you need to have the app in India, which is not the case. And we don't have the app in India for a very simple reason. There are rules and laws which are different between countries. So we can only launch an app when we have a full assessment by a lawyer. Otherwise, we may be, it's illegal. It's not difficult to do that. It doesn't cost a lot, but we need to do it.
So Deepak, from your side?
So Indranil, telemedicine and telehealth services, how to improve, it is going to come. Whether it takes 5 years or 10 years in India, it will come. Obviously, the data will come in, which will show that it enhances the compliance, it enhances the overall health-related behavior of an individual. His accessibility and accessibility to a doctor and a physician or a caregivers to get a better control of the disease. There is no going to be any doubt about it. And I'm only happy from this point of view that at least the 2 years of COVID made a lot of Indians get sensitized to telemedicine and various tele tools which can be utilized in their healthcare. So this is something which has come only because of this 2 years. Prior to 2 years, if you talk to any patient, there is nothing like a telemedicine. They have to come and see you and spend time and talk to you, and then only the things will be there. But now they know that the same thing can be done on a telemedicine. Same thing, they know that all the results can be actually, in a continuous manner, be charted by all this kind of computerized analysis and sent across to the doctor. He can check it, he can get back to you. They have this kind of now like we have got this inhalers which are available in asthma, which are able to track their adherence and tell the doctor whether you are using it or not. So all this has been now partly getting accepted into the system. I hope that because of the legalities and other things, it is not stopped, because I already heard that the NMC is trying to put in a block to the telemedicine in India again, which is something which will be very detrimental to the health, because people cannot travel the length and the breadth of the country to reach the doctor. No doubt the doctors are available, but the patients don't have that much of resources that they can go and travel to the doctors to get their treatment all the time, actually. And in chronic diseases, it is just not possible, actually. I think
at least for the follow-up, this telemedicine should stay.
I think if it's an issue is about the diagnosis on the telemedicine, that's a different thing. But on a follow-ups, on the other routine follow-ups, their monitorings, that can all be easily done with minimal resources required, as well as much less financial burden on the patients.
I cannot agree more. You're perfectly right. The only problem is I hope that the sensitized patients do not become allergic.
So, Dr. Talwar, any tools or technology that you take help for adherence of these patients, or you know that the patients are on follow-up? Any other tools?
Well, I know my tool, and I know that in rhinitis, there are only 3 tools available which have been tested.
So, can you please elaborate on those just a bit on that?
Sorry? What did you say?
A bit elaborate on the tools that are there for the follow-up.
It is allergy monitor, it is the pollen Vienna, and mascara. There are only 3.
So with this, there are some audience question also. A few of the audience has asked about the role of prebiotics. Do you use them, or do they really have some role in treatment of allergic rhinitis? Dr. Talwar or Professor Buske, we want to hear from both of you, the role of prebiotics.
Well, we published a paper showing that prebiotics are effective. So the problem with prebiotics is, number one, which kind of prebiotic are you going to use, which strain? And this is not set. But it's likely that the microbiome is playing an enormous role in the onset and severity of the disease, and this will be the next generation treatment. So pre and probiotics will be of great importance, but today we don't have enough data.
Dr. Talwar, do you really use them for allergic rhinitis?
Well, not really. I can say that I've used it in those situations, because I think we do not know what to use and how to use and which ways to use, actually. So we know that microbiome is a big thing which is going to be there now, and obviously the nasal cavities, which are taking the brunt of whatever is going in from the air, will be definitely involved in it. But by and large, in India, we are more bothered about the air pollution. We are bothered about PM 2.5 and PM 10, actually. So we are all the time wondering about how to take care of them at the moment. So even in there is a role of probiotics. There is a role of probiotics have been even in air pollution related allergic conditions worsening, particularly of the upper respiratory tract. The role has been already studied and published in some of the research papers. So there has been a talk about it, but I have not personally used it at the moment, because I don't find any guidelines to tell me when to use and how to use.
So another question that has been asked, do you think that there should be change in the management of allergic rhinitis in pregnancy?
I think
this is difficult question.
So sir, please, can you just get to that question?
Yes, but my problem is that problem to connect. So yes, this is, but we need to make meta-analysis on this to provide real data.
So is it about the prebiotics that you are telling, sir?
Can you repeat?
Is the treatment different in pregnant ladies for allergic rhinitis?
Yes, it should. And we need to take medications effective and safe.
So are the intranasal steroids and intranasal histamines considered to be safe during pregnancy and lactation?
Yes, I think so.
Oral therapies have to be avoided. That'll make the life easier in a way that there are locally acting therapies are likely to be much more safer than anything else.
Only thing is that patients with asthma and allergic rhinitis, the total dose of the steroid should be absolutely assessed, because they are taking intranasal steroid, they are taking inhaled corticosteroids also. So ultimately the total dose of steroid has to be adjusted in that way that it doesn't cross the higher limit in that way. Probably in that way it may cause some detrimental effect to the fetus. Otherwise it's very safe. Intranasal steroid, inhaled corticosteroid are safe, and they practically should be the right medications during pregnancies. So there are a few questions also, the role of antibiotics in allergic rhinitis. Are there any role of antibiotics in allergic rhinitis?
No.
Unless, yes, definitely, that's the answer. So Ketan, can we have some of the more audience question? Practically, these are the few audience questions that I got. Do you have more of audience question?
I'm forwarding them to you on WhatsApp through Dimple.
So this is the thing that I got. So another question, how do we tackle air pollution related allergic rhinitis? Deepak should be in the right place to answer.
That's the only answer which I had actually. Neil, I have no answers exactly. But yes, this is what is being pointed out, because there are certain studies which are talking about combination of Montelukast and fexofenadine being used to take care of this worsenings during the increased pollution times, to take care of the symptoms of allergic rhinitis. And that's perhaps the way we are also perhaps tend to use it in clinical practice.
So there should be some political commitment and political motivations to try away this, at least this kind of pollution. So another important question in that way. So in the pediatric age group, that should be to Professor Buske. So in the pediatric age group, coming to intranasal steroid, which should be the safest intranasal steroids for them?
Well, mometasone used very early. So it is important not to combine without need and inhaled.
So it's intranasal mometasone that you are telling. It's the safest in pregnant
Yes.
pediatric age group. Is it also safe for pregnancy in pregnant allergic rhinitis? Should we move on to mometasone, intranasal mometasone?
Well, I need to check, because what we need to do is to check the bibliography, because there's so many papers that are to know.
So another question that has been asked: do you in Europe are there any AR registry for the allergic rhinitis patients?
No.
Same thing, we don't have it in India also. And the step up, step down has questions are there, but that has been aptly dealt in the presentation by Professor Buske there. So step up, step down has been dealt with there. So a question from the audience again: will the nasal decongestant play a role in improving the quality of life? Do you think that the nasal decongestant, when used, may improve the quality of life? Definitely, practically it improves some of the quality, but it has its own side effect, and that too not for prolonged period. Dr. Talwar, any comment on that, the nasal decongestant?
I've not seen any paper.
Okay, if that is that, the audience question has practically been dealt with. Ketan, if you do have any audience question, do forward it to us, or otherwise we should wind up our session.
Yes, sir. Let's wait for 2 minutes. Let's request the participants to put in more questions. If there are any questions, we'll address them. Otherwise, we can stop.
Dr. Talwar, what I want to share with you, in India, practically, people cannot get rid of their allergens. In fact, if it's the insects or it's the dust that they are dealing with, even whatever advice or whatever, say, counseling we do to them, they cannot get rid of their allergens in the proper way. And that is the reason, even in spite of the intranasal steroid, they have to rely more on the oral antihistaminics and oral medications. What we see here, once they stop their oral medication, they again move to their symptoms, and practically they come back to us, just say, we cannot stop the oral medication, whatever you tell. So what's your experience on that? And how can we deal with counseling those patients in order to have an avoidance of the allergens?
Actually, Indranil, one of the major advantage of performing a skin prick test is to identify the allergen and tell the patient how they can have an allergen avoidance. But the issue is, you are very rightly said that allergen avoidance is never 100%. So it is only decreasing the burden of the allergen, which is a possible, and which many a times it's not possible because of the peculiar circumstances they have at home and a work environment, which does not allow them to change. The most important, like house dust mite, is the one which we most commonly try to practice by all methods available of avoidance, clearance, as well as using various protective mechanisms to let the house dust mite not come in contact with the patient. But I have found that if it's not 100% effective, at least house dust mite is something which is partially avoidable by the appropriate techniques. But when it comes to other things, like you said, that the pollens and the fungi at home and at workplaces, these are very practically difficult to eradicate them completely. So that is why they continue to have symptoms and exacerbations over a period of time and require oral antihistamines to control their symptoms.
So Deepak, I'll ask you another very untoward question in that way. So we know that combination therapy, we don't like it. We don't want to tell it in public that yes, combination therapy. But yes, we have a permutation combination of combination therapy with Montelukast, levocetrizine, Montelukast fexofenadine, and Montelukast bilastine. If you really have anything to choose from these three, because there is an audience question there. So we know now that Montelukast bilastine is coming. We have Montelukast fexofenadine. Does Montelukast bilastine has any advantage over any of those, or you go on to choose the one that has been well studied and well tried? That's the thing.
So Indranil, in my practice, what I do is that whatever I have been using in the past, I continue to use it. Whenever I find that doesn't work with the patient, I try to shift them to the newer ones and see whether it works or not. By and large, it is an experience based, because I don't think so there are head on or head very good trials which tells us A is better than B or B is better than C. So ultimately, I think the most important aspect is certain group of patients do respond well to A, certain patients do not respond well to B and may require C. And there's no one rule of thumb for like this is the best one and the rest are all useless. It is not going to happen. So we think that fexofenadine and bilastine are less sedating than levocetrizine. It's not always true. It is particularly patient to patient dependent. So I think we can't have a rigid attitude. Neither I have felt that one molecule outperforms the others. So I tend to use practically and see how patient experiences the drug, its effects as well as side effects, and then try to see that what I can do about it.
So last few questions. Deepak, you are the only one left there, so you are the person who will be answering. So your experience on immunotherapy, especially during the COVID. Do you do that, or do you really preach that yes, immunotherapy do work in COVID, and these are the subset of patients where immunotherapy will be working?
So immunotherapy works. There's no doubt about it. We use subcutaneous, not the sublingual one. And during the COVID, it was although difficult to carry on with it because some of the patients did, miss their dosages, but somehow they were they carried on during this last 1.5 years also. House dust mite is the most effective, which we find in clinical practice, including pollens, and some of the people like they have a dander allergy which they cannot avoid by all means. So for those we use immunotherapy, and I very strongly feel allergic rhinitis is an indication for immunotherapy if you are able to get a right patient and you are able to identify the right allergen and you are able to afford to get them the right immunotherapy, which is obviously not always everything possible. But then, and on this basis, we do use it, we are still using it, and we are continuing to use it.
So thank you. So practically another question which has already been addressed, that is, can allergic rhinitis progress to asthma? It's true, yes, allergy much is there. But a question that arises is that if we treat allergic rhinitis in the right way, in the right time, can it prevent it from developing to asthma? That's the question that the audience has asked.
Why don't you answer this, Indranil? Because it's a very difficult question. Because we know that adequate control of allergic rhinitis is required for management of asthma. We do know that untreated allergic rhinitis will lead to development of asthma in a couple of cases, maybe 60% or 40% or 50%. There are different studies showing that. But if you treat them well, treat them early, will it prevent from them getting asthma, them becoming asthmatic in later years of their life? I do not know the answer.
That's the thing. So thank you. Practically, we are seeing that Dr. Meghnad has joined lastly. So any final comments from you, sir, about how you diagnose your asthma patient? Because we were trying to ask as an ENT specialist, how do you diagnose your allergic rhinitis patients? So, or some comments that management of allergic rhinitis during the COVID, do you have something to tell to the audience? We cannot hear you, sir. You are muted. Please do unmute yourself. Please unmute, sir.
I think we have cleared everything very clearly. As an ENT surgeon, I would like to do a nasal endoscopy and nasal smear for eosinophils. These are the two investigations which are very useful and very handy for us. Apart from that, I think controlling the allergic rhinitis definitely reduces the risk of asthma. I've been practicing for the last nearly 30 years in the city. I have few patients whose families are coming to me, and many of my patients' families who had, I think the grandfather had asthma, the son had asthma, but the grandchildren didn't had any, haven't developed asthma after they were treated with antihistamines for their allergic rhinitis.
So thank you. With this, I thank Professor Buske, Dr. Talwar, and Dr. Meghnad. And I should hand over the session to Dr. Ketan to just finish up the program.
Thank you, sir. I mean, no comments from my side. It was an engaging discussion. We did have some technical difficulties, but yes, we covered everything, and we are about 10 minutes early from our scheduled close. So I really thank everyone, Dr. Haldar, Dr. Talwar, Dr. Meghnad, and also Professor Buske for being here and giving their time for us. And also special thanks to the participants who have been attending the.
So thank you. So except Deepak's
Thank you very
network,
much.
all of our network was there was a flaw in the network. So thank you, Deepak. Thank you. Thank you.
Thank you, Dr. Haldar.
Thank you.
Thank you, Sanofi, for giving us an opportunity to meet our friends.
So lastly, I should thank Dimple for making the arrangement in this hurriedly. So I had to stop my clinic in the mid.
Thank you, sir. Thank you. In fact, it is joint effort, sir. We managed this, and I'm happy we could complete the seminar on time and with a fruitful discussion.
I knew that there will be a problem with the network. I knew that in my clinic, I don't have a very good broadband support. Initially, I started with the laptop. Then the laptop was a failure. I went on to mobile. Mobile